Thank you. Good morning. It's a great pleasure to be with you. I'm very pleased you can make it, Dr. Park. I understand the snow has been extremely heavy. So I hope you can all hear me. I have the great pleasure this morning of presenting to you some of our department's work in this field. I apologise for the slightly lengthy title. But the general hypothesis of this talk is that we can use mass spectrometry intraoperatively to augment decision making. And I'm going to present some of our most recent data to support that hypothesis. And I'm briefly going to start by reviewing the unmet need. Now, in any form of innovation, one has to understand the historical context of what we're trying to achieve. And cancer surgery, of course, goes back many thousands of years. We've known since Hunter in the 1700s that to treat a cancer and to get effective local cure, one really needs to not just treat the cancer itself, but one must remove the lymphatics. And of course it was, although Billroth might be considered, sorry if we could just move the slide on, I don't know if that's fantastic, there it is, you can see Sir John Hunter there. We've known, if we can move on again, that when Halsted first described the radical mastectomy, he was able to significantly reduce local recurrence rates, and he did this, of course, by excising the lymphatics. Now, the modern oncological surgeon has to deal with a lot more interventions than Halsted did. We've had significant advances in our adjunct therapies, in our surgical approaches and minimally invasive surgical techniques. And of course, the emphasis now on the surgeon is not just to cure. Of course, that's the main goal that all oncological surgeons want to achieve. But quite often it's to diagnose or indeed to offer accurate prognosis, not just staging, but molecular staging. And most importantly, to ensure that our patients have good function and quality of life and to keep them safe. But the basic premise of all oncological surgery, if we could just move on please with the slides, is that we want to remove the cancer itself and a healthy margin of tissue around the tumour. Now, this is, of course, often decided by the histopathologist, not the surgeon. And it's difficult to try and identify this often intraoperatively. And this remains a reasonably controversial area within surgical practice in numerous different surgical specialities. So breast surgery produces a very nice example of why this is so controversial. I'm going to talk through several areas just to give you an idea of the current major issues that we face. But this is data that came out of the UK's hospital episode statistics, and it demonstrated that nearly 20%, if we can move on, 20% of women having a breast conserving surgery in the UK have a positive resection margin. And of course this has a significant effect if they have to undergo reoperation, not just in terms of cancer prognostic outcomes, but also in terms of cosmesis and in terms of the socioeconomic impact for the healthcare provider. What you can see here is a funnel plot of UK data of reoperation rates in these women having surgery. And interestingly, it is used as a quality measure, and you can see a range of effects. And as we know, there's a volume-outcome relationship, and the more cases you do, the lower your reoperation rate, but it's certainly not a linear relationship. So what's interesting is that if you look at international guidelines for how much normal or healthy tissue we should be removing around tumours, they are highly variable, and then they are rarely completely in agreement, if you could move on. So here what you can see next is the data highlighted between the UK, the US and Australian guidelines in the treatment of melanoma. And there's a reasonable degree of disagreement there as you get an increasing breast load thickness. And what's interesting in the recent Cochrane review is that this doesn't really seem to impact very dramatically on outcomes depending on how much margin you take. Next slide. So there is now increasing controversy in other areas of surgery as to whether or not we should be changing our patients' management based on the microscopic involvement of margins. And this was a controversial paper published in Annals last year out of a group in Paris. They make the point that, of course, cancer is a three-dimensional disease. The distal margin really is the true margin if you're going to describe an R1 involvement, but also, of course, in cancer of the rectum, we worry a lot about the circumferential resection margin, and usually 1 millimetre or less is deemed to be a positive margin. But we also worry about nodal involvement, and they separated out these patients in a retrospective series of about 470 or so patients. what they found when they looked at the outcome data is that actually having an R1 resection margin didn't necessarily influence your local recurrence rates, but it did significantly impact on your disease-free survival and your overall survival. And what they found that actually, if you had an R1 resection rate, your risk of having systemic recurrence was much greater, and primarily in the lung. And that obviously has significant impact for how we manage these patients in the perioperative period. So, of course, the cancer MDT has radically changed how we manage our patients in the last few decades, and particularly the goal of the MDT is highly accurate preoperative planning, and imaging has had a really significant impact on that. I'm a colorectal surgeon, and in the planning of rectal cancer, MRI of the rectum has been transformative. But it's still not accurate all of the time. This is data out of a systematic review and meta-analysis published by a Toronto group and Professor Brown at the Royal Marsden Hospital, looking at about, I think, 19 studies and over about 1,900 patients in each arm. And what they found, although it has high specificity for detecting a CRM preoperatively, it doesn't really tell you that much about lymph node involvement or indeed your T stage. Next slide. Now, and if we can go on. So the advances really have been in molecular phenotyping of cancer. Now, you can't read all the data on that image, and that's probably the point, because there's a lot of biomarkers there to help us make better prognostic predictions for our patients. Next slide, and on again. But there's very little data to help us make operative decisions, so to guide the type of operations that we should be doing for our patients. And in early rectal cancer, this is a specific problem. Should we be following a model of breast cancer where we should be doing limited resections and organ preservation where we can? And this is a very important area of debate. What's interesting, if you look at the ROCKOVs there, this is a study that looked at methylation, DNA methylation, genetic methylation in about 130 patients with rectal cancer. That, yes, we can make reasonable distinctions about who's going to have poor histological prognostic biomarkers, but actually the ROC curves there, I think we can improve on. Next slide. So, if we summarize the problems with the cancer margin, quite often we ablate it or we destroy it when we operate on it. It's not standardized, and certainly intraoperatively it's not objective. The definitions are often dynamic, and if you change those definitions, the R1 rate will change, and that's probably well exemplified by the recent SSO ASTRO guidelines in stage 1-2 breast cancer, which came out after a meta-analysis recently, where they changed it to tumour on ink as a definition. It is tissue and stage specific, so as your cancer changes, so does the margin, rather obviously, and it's dynamic. As we use increasingly amounts of neoadjuvant therapies, it's more difficult to identify, and a good example of that is in complete pathological responders in early rectal cancers. About 30% or so will completely respond, and we don't know at the moment what to do with these patients, although we're hopeful that we will have data to inform that decision soon. It rarely gives you information on tumour biology, so you might know the margin, but it doesn't really tell you about how aggressive that tumour is. The study that we highlighted on out of Paris, one of the key indicators that were of important prognostic value were not the resection margin, they argue, but actually whether or not there was lymphovascular invasion and how aggressive that tumour biology was. But despite all this, it's often used as a qualitative measure of surgical performance. So, next slide, please. So what we're interested in is precision surgical oncology. Next slide. Now, you will have all been aware in the US, I'm sure, about, next slide please, of President Obama's commitment to precision medicine. He's recently announced a $215 million budget to drive forward this program. $70 million of that will go to the NCI for genomic phenotyping of cancers to help make decisions. But what we're really interested in is precision medicine or personalised healthcare, which really means getting the right treatment to the right patient at the right time. Or in surgery, it means really doing the safest operation and the right operation for the best possible outcome for our patient, for the best or lowest economic cost. And we do that by coupling established clinical pathological indices with molecular profiling approaches to aid our diagnostic, prognostic and therapeutic approaches to managing cancer. Next slide. So intraoperatively, of course, it's tempting to make the assumption that precision medicine simply means making more accurate cuts with a knife? Well, it kind of does to a degree. At the moment, though, we have few tools to really help us do that. Frozen section would be a standard approach, but it's not really scalable. It's quite costly, it's quite slow, it increases operating time, and it's resource heavy. You need someone to look at the tissue slide. Next slide, please. There have been a number of emerging technologies to try and help us change these things, and I know, I think Beth Israel are on the call today, or at least I hope so, and I know some of the groups listening will have had experience of using these technologies. The margin probe has been around now for some time. I think it's been around since about 2004, and certainly it's got FDA approval. And it largely, all of these techniques rely on some form of spectroscopic analysis of the tissue, but quite often they don't necessarily provide information if you're interested in biomarker discovery, because you've got to have some sort of a priori knowledge of the tissue that you're studying before you begin to analyze it. There has been some data on their use. I haven't specifically included, by the way, data on optical biopsy or on endoscopic therapies, because they obviously don't rely so much on spectroscopy. There's been a recent systematic review and analysis of this in breast cancer, and you can see that there is a lack of data really on how these technologies influence patient outcomes. We don't have good randomized controlled trials yet to suggest that we can actually improve long-term survival with these approaches. However, we do have some data on sensitivity and specificity, and there appears to be a degree of variation in how this is reported. It's not always reported with the positive predictive value or the negative predictive value, and we think this is obviously a key statistic, because if you're going to tell a patient that they do not have cancer at their margin, you need to be absolutely sure, because the consequences will be significant. You'll see, of course, that the frozen section, it's got a very high specificity, but the sensitivity is not 100%. Next slide, please. So what we're interested in Imperial College is molecular phenotyping. Next slide. So there are some broad principles of molecular phenotyping. Next slide again. And really what it involves is some form of high throughput analytical approach where you get large amounts of data. Can we just run through the animation on the slide, please, if you keep running through? In this case, you'll keep getting spectral data. Okay, that's great. So you can see that what you'll end up with is a spectral database which is validated against some histological data set. So every spectra that we take out of a patient we validate with histology. Then what you are able to do is to build a set of multivariate models based usually on a supervised and an unsupervised approach. We typically use principal components analysis, which is a projection-based method, or linear discriminant analysis. And when you then have an established model with an unknown in that data set, you can make a prediction as to what the original class of that spectra is likely to be. Next slide. So we are very lucky at Imperial College. We have a facility. We've effectively had an Olympic legacy project where we're able to take over the drug testing facility from the Olympic Games in London in 2012, and we're able to apply these sorts of technologies to very large populations to do biochemical molecular epidemiology effectively. But clinicians obviously need an array of different tools, and surgeons need information which they can make decisions on in near real time, and that often means being able to process these data within seconds or less than seconds. And that brings with it different analytical challenges, different computing challenges, different spectroscopic challenges. Next slide, please. I'm going to show you just some examples. If we just keep pressing next slide and run through the animation. So this is an example of a mass spectral imaging. I'm going to talk about the iknife, but I need to show this to you to make the iknife make a little bit of sense. So mass spec imaging, we're allowed to fire ions we effectively fire a laser at tissue. It kicks up ions, and we're able to then reconstruct those ions into an image, from which we can augment chemical histology. Next slide, please. When you look at these images from a biochemical perspective under the microscope, what's interesting is that we can differentiate out borders which we think are important in margin detection. So you can see, if you go to the next slide, you can see that you've got a red patch, a green patch, and a blue patch. This is from a colorectal specimen. The blue patch, the green patch, I should say, is healthy tissue. And you can see the blue patch there is the tumour microenvironment. So we think we can visualize abnormal changes in metabolism around cancers, which we think we can sense in near real time by using the iknife technology. Next slide. And there's a group in Harvard that has been using this technology to try and see if they can sense breast cancer tumour margins ex vivo. They've not moved to an in vivo data set yet. What you can see there is their early data in a single specimen that's come out of a patient. In row A, you've got tumour data. B is tumour margin, C is 5, D is 10 centimetres, and E is the contralateral breast. But what you can see is in the columns individual metabolites and mass charge ratios. So you can start to build up models based on either single or multiple different metabolites to give you accurate information about tumour margin status. And we can visualize that. We can visualize those metabolic field changes with the process of augmented histology. So that took us on to trying to understand why we see these changes, and what we're predominantly measuring, next slide please, is the cancer lipidome, the changes in the mucosal lipidome. You'll all be aware of the Warburg effect in cancer. Well, as part of this, what we see is changes in membrane expression of lipids. If you can just run through to the next slide, please. And lipids in cancer have a number of different roles. They're obviously they have importance as molecular signaling molecules, but they also are obviously important in maintaining membrane function. What we also see is an overexpression of very long-chain fatty acids and branch-chain fatty acids in these specimens, and we hypothesize at the moment this has got something to do with autoperoxisome function. So it's basically lipidome-based. Next slide. So that gives you a brief overview of the clinical problem. I'm sure all of you work in different fields will have different appreciations of this particular controversial issue. I've given you a brief introduction to precision medicine and precision surgery and introduced you to the idea of chemically augmented histology, and I'll take any questions at this stage.
All right, thank you, James. We'll pause for some questions and comments. Again, I will encourage all who are attending to call in to let us know to come to you. But I do want to start with our own Dr. Lorraine Taffer. She directs the leading breast center in our state. I'm biased, but and Lorraine, can you just talk to us a little bit about how big an issue this is of the problems that you need to solve in breast surgery? How important, how much of a priority is getting the margins right and being able to do this in real time? What would this add to your field?
Yeah, so James, wonderful presentation and very exciting. So margins for breast margins are of course the bane of our existence. Very, very challenging. And the part of the challenge for us is that we don't have any good tool right now. So you mentioned the margin probes, and there are a number of them, and I'm quite familiar with the data coming out from that technology, and it's not tremendously helpful. And part of the reason it's not tremendously helpful is a point that you touched on, which is that it doesn't characterize the tumor cells for us. So frankly, it really doesn't matter what's at the margin. I mean, it really doesn't matter that there's something at the margin. It matters what's at the margin, right? And the characteristics of the tumor, you clearly touched on that. So going forward, of course, for I think all of oncology, certainly for breast, it's all about tumor biology, and this is something that you're obviously getting closer to. So I have a couple of questions for you. The actual technology for looking at the tissue, that technology, is it a big machine, a little machine? Can it be in the operating room? Can it be on fresh tissue? Can it be on your lumpectomy specimens?
Okay, so that's a great question, and I'll answer that question for you in detail in the second half of the talk, because I'm going to show it to you, and you'll be able to see it function. But the answer to your question is, it's like any technology. At the moment, the machine is on wheels, it's mobile, we move it around the hospital from the endoscopy suite to the operating room, but it's quite bulky. We work very closely with the Waters Corporation, who are a large US-based manufacturer of mass spectrometers, and we foresee that technology becoming more manageable and smaller. At the moment, because we are in a discovery phase of research, if you like, we drive the Ferrari of mass spectrometers. We drive the mass spectrometer that does absolutely everything and gives you very, very sensitive information. But once you've done the discovery work and you know what you need to measure, you can drive the Mini Cooper of mass spectrometers. You need a more functional instrument, and I think that's what we will see happen. I want to come back to your point about phenotyping of cancers. I couldn't agree with you more, and I will hope to show you some data in the second half of the presentation, because I agree. I think we need tools that simply tell you more about the margin. It needs to tell you more about, if you're going to hit a margin, and we all try to avoid that obviously, about the type of tumour that you're actually operating on. And quite often the surgeon needs to know about that probably before they've hit the OR. So we're working on minimally invasive diagnostic tools that can take advantage of this technology to really inform decision making at all stages of the patient journey.
Thank you, James. We'll go to our colleagues in Strasbourg. I want to ask a question for our colleagues in Strasbourg. Good morning. I know, Bernard, good morning. See you there with your colleagues. Didier. I know you do a large volume of GI malignancy surgery, and what's your current? What are the current techniques and methodologies you guys use there to speak to the margins issue? Anything close to real time, or do you do what the rest of us do? Using frozen sections?
We don't have the solution as today. You know that we've been involved quite soon in the development of confocal microscopy, and that's something we're looking for, is just to try to test the ability of this confocal probe to provide information regarding your resection margins during oncological surgery. But it's really starting, and you can imagine that when we are working with a 2 millimeter in size probe and assessing the margin of resection when you're doing right hepatectomy can be quite challenging. So we know the limitation of these tools today, and probably these microscopic confocal systems are probably more relevant for analysis of the mucosa, for example, for all the GI work, Barrett's esophagus, cancers, etc., within the mucosa. And we're still facing some big issues when we're talking about resection margins of larger specimen because of the size of the instrument that would take hours to check a good size specimen. So I think that's why we are so interested in this new technology, because that can solve maybe some of the problems.
And thank you, Sylvain and Didier as well. Okay, James, why don't we continue on? I don't know if you're going to speak to any of these other technologies. We had interest in the use of non-visible light. Some of these technologies came out a few years ago. The confocal microscopy, as Bernard mentioned. Anyway, look forward to your continued comments.
Okay. Thank you very much. So great questions, and I completely agree with the discussions before, the comments that some of the previous questioners made, but we'll move on. Next slide, please. I'm going to show you just a very brief video of how the technology works. So you can see in the animation that's going to fire up, with luck, a simulated liver metastasis being operated on, but obviously this could be anything. So the device doesn't really require the surgeon to have any other technology in the operating room that they would normally have. We use standard electrocautery. It can be any instrument that creates heat or energy, because that creates ions, and mass spectrometry senses ions really as a function of its mass charge, and it displays that in the spectrum. So we have a little chimney in the device that we've manufactured. Otherwise, it's a completely standard handheld instrument. Rather than discarding the smoke, we suck the smoke up through the instrument into the mass spectrometer, and we do that in about 100th of a second. A lot of the technology has gone into creating stable ion transfer, because obviously they decay the further you go along the tubing to the instrument, and we need to keep them stable as we can, and it creates debris and particulate matter which can block the machine. So quite a lot of technology has gone into it. But the feedback to surgeon is near instant. So at the moment we feedback with red if it's cancer, green if it's likely to be normal tissue, with an overall accuracy plot. And we also describe the histological subtype of the tissue that we think it is. Just to show you a little bit of the working of the machine, mass spectrometers come in lots of different shapes and sizes. This is a Waters machine. And we use a number of different steps within inside the machine to separate out the ions, so that you get very specific information just about the molecules that you're interested in. Now, what happens to molecules when in typical mass spectrometry is that you ionize them by firing electrons at them. We don't need to do that in surgery, as I've mentioned, because you have heat. But we will then use a number of different techniques. This is time of flight. So what you do is if you basically bounce ions inside the machine, those of different mass will obviously take longer to fire, and it improves the sensitivity of the machine. And that's what I was referring to when I said we have the Ferrari of the machine. And that's what the feed looks like. So I mentioned to you before the basic methodology. We have a large validated histological database of numerous different cancer types. And we used predominantly linear discriminant analysis, which is a type of supervised multivariate analysis to try and predict the origin of the spectra as they come out in real time. So next slide, please. So that's basically what the device does. If we look at the spectral data in a little bit more detail, next slide, what you can see is what we're actually measuring. So what we're actually measuring is phospholipid. Those are two raw spectra that have come out of a patient. You can see a healthy liver tumour specimen there and a metastatic liver specimen. And you can see the changes in the raw spectral data. So quite often what we're measuring really is glycerophospholipids, so phosphatidyl serines, phosphatidyl phosphatidyl glycerols, and we predominantly use a specific mass charge region. So we predominantly use about 600 to 1,000 range of the spectra to make our analyses. We don't necessarily see expression of different species of molecules, but we will see semi-quantitative changes in those species, which we use to build our models. Next slide. So this is the machine actually being used in practice. If you could play the video, apologies, it's a little bit jerky. But this is my colleague, Mr. Daniel Leff, who's one of our oncoplastic breast surgeons here at Imperial College using the device. And you can see he's doing the operation, sorry, you can just go back, that's right. You can see he's using, it's a completely standard operating field. Nothing really changes for the surgeon. At the moment, we're not at a situation where we can get the surgeon to make decisions about their operations in vivo, because we don't feel we have the data and we don't feel it's ethically a suitable thing to be doing, but we're working towards randomized control trials. The video is very slow, so I do apologize, but what you should be able to see is the machine just sitting behind him, but I think it's going to take forever, so we'll move on. The next slide, please. Yeah, that's great. So this is some data that came out of resected liver metastases. And the first thing that I'm going to make a point is that you don't get a black and white on-tumour, off-tumour metabolic signature. The plot on the left is a principal components analysis, so that's an unsupervised approach. There's no a priori information given to the model as it builds. And you can see that you get separation of the metastatic tissue away from the colonic border, from the malignant tumour border, but the benign tumour and healthy liver parenchyma cluster together. When you apply a supervised approach, you can create, if you like, a regression extension. You can maximize the differences between the clusters, and you'll see that you progress as you go through it. And broadly, what we think we're measuring is what I was showing to you on the DESI, on the desorption electrospray ionization mass spec imaging. These are not liver specimens, I should say, on the image, but if you go to the next slide, sorry, what we're seeing is that border of tissue which is abnormal. And the next slide, please. And we're measuring that in vivo. So next slide. What we focused on at the moment is really diagnostics. So we're not at the moment at the stage where, as I've mentioned, where we're actually asking surgeons to make decisions about involved tumour margins in vivo surgery, but that's where we want to be. I'm going to show you some early data from our breast cancer work, which we've got going on prospectively here at multiple centres in London. So we've looked at this data is from 8 women with cancer, 15 women with benign lesions in the breast, and 44 healthy women. Next slide, please. This is what the raw data looks like when it comes out of the machine. So you can see clustering of normal breast tissue, clustering of fibroadenomas, and the invasive ductal carcinomas are less tightly clustered, reflecting probably increased heterogeneity that we see within these specimens. Next slide. And each dot there, of course, represents a single spectrum at a point in time. So that's about probably several hundred or 1,000 or so metabolites that we're measuring at that one point. What we get when we look at the data, is we put a lot of emphasis on cross-validation and ensuring the robustness of our data sets, because if this is going to work in a patient, we really have to be sure of its diagnostic accuracy. In basic terminology, what we end up with is a confusion matrix, brilliantly entitled, I felt, because it can be quite confusing. But you get essentially, next slide, you get an overall accuracy score, and you get an assessment of the true positive, true negative, next slide, and false positive and false negative discovery rate of each individual patient as you go through it. Next slide. So if we look at some raw data, I've mentioned that what we're interested in is not just margin detection, it's tumour phenotyping. Now, we'll look at this data. What obviously we're able to do is measure different tissue types. So there is obviously a difference in the lipidomic content between adipose tissue, connective tissue, and tumour tissue, and we can separate out this quite nicely. And you can see the overall total accuracy of those different tissue types. I'm not showing you the raw spectra because I think it's not going to be particularly helpful. So we can tell the difference between different tissue types. Next slide, if you can. And we can also tell the difference between different grading. And these are different lipid species that are allowing us to do this. And like I said, it's several hundred lipids that we're measuring at one time, which are allowing us to make that distinction between tissue classes. If we go to the next slide, sorry, that's great. What we're seeing is reasonable diagnostic performance of this device, at least in breast tissue, and we're able to not just distinguish tumour type, but the estrogen receptor status and the tumour grade with a reasonable performance there on the area under the curve on the ROC curve analysis. So the diagnostic performance is close to histology. I mean, that's a slightly inflammatory statement, but it's designed to try and stimulate some discussion. And what we hope is that we're able to get data that is similar to immunohistochemistry, and we get one analysis to measure multiple parameters based on the analysis of multiple different lipid features and small molecule features of a tumour as you're biopsying it in near real time. So if we've got new questions, do we need new methods of data analysis? Well, probably. Next slide, please. This is to give you an example of other areas we're applying it. So this is neurosurgery. We work with our surgeons over at Charing Cross Hospital. I'm not a neurosurgeon, so I don't claim to have expert knowledge on the topic. But just to give you an example, obviously in neurosurgery, it's incredibly important that you maintain healthy tissue wherever you can, because the consequences for the patient will be really very dramatic and potentially life-altering. It's not like a melanoma where you perhaps got a centimetre of skin to play with. What you've been able to see there as the animation has run through, as you go through each different anatomical layer of the linings of the brain and into the brain tissue as you go through, you get different spectra. So you can help augment, not replace, but augment imaging technologies that guide the surgeon in real time during surgery. And you also get data on the tumour type itself. In our original paper, which I'll come to in a second, in Science Translational Medicine, which we published at the end of 2013, we were able also to tell the origin of different types of brain metastasis based on the lipidomic spectra. So, we've really, I think, are just beginning to get started on mining these very large data sets for their clinically useful data. Next slide. I'm a colorectal surgeon, so that's what I'm really interested in, and what we're really trying to push is translation applications in this field. We've submitted our data to ACS, and I very much hope we'll be able to present it there to you. But this is hot off the press from one of my PhD students' work, which we pushed through in time for this presentation. But what you can see there is a mucosal sampling of 40 colonic cancer patients. And you can see the cross-validated scores plot on the top left-hand side. The little green numbers where they've got a red square around them are samples that have been incorrectly classified by the model. So we're not getting 100% sensitivity specificity, but we are getting a pretty accurate model, and we're able to give information to the endoscopist or surgeon, we hope, in near real time. Next slide. Which might also be of useful, might well be of use to them. So much like in the breast, we're able to make distinctions on tumour biology based on the lipidomic signature. We can do the same thing in colonic and rectal cancers. Now this data is just from rectal patients with rectal cancer. So it's only 10 rectal cancer patients. It's a small number, so we need to keep that in mind when we interpret the data. You can see that, again, the performance for detecting lymph node micrometastasis, extramural vascular invasion, or KRAS mutations is reasonable. And we're able to get fairly accurate class separation. EMVI, I think there's a little bit of overfit of the model there, and we need larger tumour numbers to really improve on the validity of that data set. But we have clinical trials ongoing with that, and I'll explain a little bit more of that as we go forward. Next slide. So this was summary data that came out of the original publication in Science Translational Medicine. We identified these signatures in over 525 interventions. That was ex vivo and in vivo data. The in vivo data was captured with a slightly different device, but nonetheless, we were able to reproduce some of the in vivo data that we accumulated ex vivo. And what we did was we looked across a large number of different tissue types, because we want to see the performance of the device. And we got a pretty good degree of classification. And that inspired us to take this on and to try and do high-quality prospective work to see if we could repeat this in better constructed randomized controlled trials, and that's what we're doing. Next slide. So I mentioned to you before that yes, it's important for the surgeon to have this device in his hand, whether he's doing it, or her hand when he's doing intraoperative or laparoscopic surgery. But we are also interested in trying to develop diagnostic tools, and we've been particularly interested in deploying this technology into endoscopy or other forms of minimally invasive diagnostic technologies where we think it may be of benefit. So we've done a bit of prospective work in the endoscopy setting, both upper GI and colonoscopy. My colleagues from the upper GI have done this work. It's certainly something that we're extremely interested in. So I'm going to present to you the colonic work here. So what we were able to do is simply take a standard endoscopic setup with a standard endoscopic snare. We attach a little bit of PTFE tubing to the side of the snare so we can aspirate gas as you use a standard electrocautery instrument. So we typically use cutting diathermy on a standard setting. We need a very, very small amount of tissue to burn to get data out of it. Now, an obvious disadvantage of the technique is that it is destructive. It requires energy. But Professor Takats, who invented the technology, has trialed this with aspirating basically mucus out of the gut, and it seems to work as effectively. So we can aspirate mucus, analyze that, and we get effective data sets out of it. So we think going forward it doesn't have to be destructive. Next slide. What's interesting is if you look at the colon, different geographical locations of the colon have quite distinct lipid signatures. So you can see an obvious illustration of the colon on the left, and you can see an LDA scores plot on the right with little dots reflective of different anatomical components of the gut. If you just run along the animation on the slide, I'd be grateful. So what you can see is if you, as you start to buzz different bits of the bowel, that's great. You get different, and just keep going. If you just run it all the way through to the end, that's great. You get different spectral signatures that correlate quite closely to different areas of the bowel. Now, when they trialed this initially in Hungary and in Germany, they were able to differentiate between not just different types of cancer, but inflammatory disease and malignant disease of the bowel with a reasonable degree of accuracy. If you just go on one more slide, please. And keep going. Apologies for the number of animations. And keep going. That's great. Yeah, so you'll see that data there. So you can distinguish out inflammation from cancer, again, because obviously it has a different expression of lipids. Next slide, please. So what's interesting is that we obviously have a debate in colorectal surgery about where the rectum ends and the sigmoid cancer and the sigmoid begins. This is the same. This is our data set on the 40 patients I showed you before. What you can see is on the top left-hand corner, again, an LDA schools plot with mapping of the bowel. Each dot is a single spectrum of several hundred data points. And you can see that the rectum and the sigmoid do separate out, but there's next, if you just press on the next slide, there's two patients there that seem to have, or if you go back one, you might have missed it. You'll see two patients there whose rectal tumours are behaving as sigmoid tumours. We don't know why, but it's an interesting idea for us that we could chemically augment histology and indeed anatomy. Next slide, please. Obviously, we worry about depth of invasion when we manage these tumours both endoscopically and in open surgery. So our next question was, well, how sensitive is this? Do we get different lipid signatures as we go through the different layers of the bowel? So we did this analysis, and sure enough, we do. So this is the raw spectral data. You can see differences just with the naked eye between the mucosa, submucosa, and smooth muscle. So the application here may be that you're improving the safety of endoscopic mucosal resection. It may be that you're ensuring that you've got clear, deep margins as you perform the resection. And there you can see the scores plot, which just validates the principal components analysis, which validates the data. Next slide, please. And again, that's the confusion matrix. So you can see the sensitivity specificity data between the different layers. And it was really the difference in smooth muscle, which significantly improved the performance of the model. Next slide. So in this limited talk, I can really only talk about the oncological functions of the device. It's interesting because bacteria have lipids in their cell wall. We don't just measure mammalian biology, we can also measure prokaryote biology. Next slide. So we can sense species of bacteria within in vivo and ex vivo systems. What you can see there is H. pylori positive and negative gastric mucosa, and we can measure that out with very accurate and repeatable data. But we can actually do this for a number of different species, and we've published our data for Ream's identification of bacterial species recently. That work was done by Nicole Stretmeyer, who's in our group, and we're excited about the possibility of real-time bug diagnostics. And of course, we've done the same data in gastric cancers as we've done in colon cancer, and you can see the different types of gastric tumours separating out on the scores plots. Next slide. So I'm going to conclude now. We need to provide oncological surgeons with data in the OR and along the entire patient journey that doesn't really just give them information about cancer margin status, but which really gives them accurate in vivo molecular phenotype data on tumour biology, tumour heterogeneity, and this is not just for the surgeon. The surgeon works as part of a multidisciplinary team, and all of whom need to make decisions on treatment planning. We are interested in applying this technology to trying to see if we can predict therapeutic responses, particularly in radiotherapy and in chemotherapy, and that's part of our work going forward. What we need, though, is an integrated solution. I don't believe that Reams in itself is going to be the only solution. As many of you know, you're working on similar technologies. And really, systems medicine describes integrating these multiple different omics approaches, whether it be genomics, metabolomics, proteomics, etc., and creating a hospital system that allows us to integrate these systems and augment our clinical decision-making based on the current therapies and strategies that we use today. What we're doing is integrating Reams data with DESI data and various other forms of spectral imaging technologies to try and improve the sensitivity and performance of our devices. And of course, ultimately, what we really need to do is prove that we can improve patient outcome data, improve patient outcomes and improve the safety of our operations that we perform. That is our long-term goal. We are not there yet, but we are working towards it. Next slide. And next slide. So there's numerous challenges in this field. I think anybody working on real-time or bedside diagnostics or in vitro diagnostics will have similar challenges. And we have real challenges in how we deliver this technology, how we engage with not just surgeons but our patients, and how we address some of the ethical challenges that we're going to have if we're suddenly going to start changing our operative decisions in real time. We now need to educate surgeons in the advances in bioinformatics and computing, because we're going to have to make sense of this information if we're going to be able to robustly interpret it and decide which technology we're going to use and how we're going to deploy them. And of course, patients are going to be key partners on our journey as we go forward and do this. Next slide. I stand on the shoulders of giants. There's many people involved in this work. I'm but a small part of a large team. I must specifically thank Professor Takat, Professor Jeremy Nicholson, and of course Professor Arudazi. He sends his apologies. He's operating at the moment. And I must also thank Ed St. John, who has been extremely helpful in setting this up and has performed a lot of the breastwork along with Mr. Daniel Leff. I'll take any questions if you have any.
Thanks very much, James. Absolutely marvelous. And one of the comments you made a while back was you're submitting this to the college, and so all of those who've just submitted our hernia and reflux abstracts are feeling particularly unworthy at this point in time. But I would like to go. I'd like to go to our colleagues at Beth Israel, and we've just got time for one or two questions or comments. So Mount Sinai, Beth Israel, we got our colleagues there. I see Dr. Naman and the team. Barry, what's it going to take in New York, in a busy hospital such as yours, a large oncologic practice, to adopt this kind of technology? What's it going to take to change practice? Understand there's a ways to go, but what are your impressions and comments?
Well, first of all, congratulations, Dr. Kinross, on the work you're doing. Fantastic presentation. I'd also like to thank you for showing two giants in endocrine surgery, John Hunter, who discovered the parathyroid glands, and of course Halstead, who's the father of endocrine neck surgery. As an endocrine surgeon, they're very important to our specialty. You know, I have sort of a philosophical question for you. We, in the field of endocrine surgery, particularly endocrine oncology surgery, we're moving more towards molecular phenotyping prior to surgery, getting information on tissue phenotyping that directly impacts decision-making before surgery as to, number one, whether or not to operate, and number two, what type of operation and what extent of operation. And I have some concerns just about having this massive amount of information in the operating room, how it's synthesized, how you keep your eye on the ball when you're doing an operation with all sorts of information flowing already in a very complex environment, and then you sprinkle in nursing, students, whatnot. And I'm not saying there's not a role for this technology, because point-of-care oncological molecular testing is very exciting and definitely can help us improve intraoperative decision-making. But the implementation does raise many ethical concerns that you just sort of touched upon in your last slide. And I'll throw that question back at you. How do you recommend that we implement this? Because there are some great challenges.
Thank you for a really important and great question. So I will start by saying I don't know about some of the other surgical residents that are watching this, but I pretty much went into surgery so I would never have to do biochemistry ever again. And it was a mystery to me as I ended up doing a PhD. I say that because I'm fully aware that no surgeon is going to have the time to interpret a mass spectrum. Okay, they're just not going to do it, and they don't have time during the operation to consider it. So we have to think about how we're going to analyze data, how we're going to simplify it, and how we're going to present it to clinicians to allow them to make effective decisions. We don't have the answer, but we're working on it, and it's a very significant challenge. As I alluded to, and as I think you've alluded to as well, I think there's going to be a degree of alignment of technologies and coming together of technologies. I don't think one technology is going to produce the definitive solution. And so the other challenges, of course, is how we integrate them to provide useful and meaningful information to change practice. This is a question we want to solve with the rest of the surgical community. We really want to collaborate with anyone out there that's interested to try and solve this problem.
Well, that is wonderful, and I think a great comment to conclude with. In the interest of time, we need to conclude. Dr. Kinross and your team, just a tremendously informative and compelling presentation. We'll definitely want to be staying tuned to the developments in this space. I just want to alert everybody to our next program will be on April the 3rd. The topic will be laparoscopic reoperative colorectal surgery, presented by Dr. John McGilley at Duke University and moderated by my colleague Steve Wexner. So on behalf of Innovations in Surgery, once again, thank you so much, Dr. Kinross, and all of you for attending, and we'll see you next month.
Many thanks. Thank you indeed. Thank you.